So about malaria. So this malaria, it is caused by Plasmodium falciparum. It's also caused by Plasmodium vivax and ovale, as well as Plasmodium malariae. So malaria can be caused by either uh, Plasmodium falciparum, Plasmodium vivax, ovale and Plasmodium malaria, and it is also caused by the zoonotic simian parasite. It is Plasmodium knowlesi. Okay, so these are the different Plasmodium species which causes malaria. So how is this transmitted? So this malaria, it is transmitted by the bite of the female Anopheles mosquito. So how is this transmitted? By the bite of the female Anopheles mosquito. And this malaria, which mosquito? Female Anopheles mosquito. And this malaria, so this occurs throughout the tropics and subtropics. Okay, coming to the life cycle of malaria. So in the life cycle, so there will be a female Anopheles mosquito. So when it bites humans, what will happen? So it releases sporozoites into the blood. So from female Anopheles mosquito, sporozoites, okay, sporozoites are released into the blood. So these sporozoites, so they enter the liver in 1 to 2 hours. So these sporozoites, so they enter the liver into 1 to 2 hours. And after they enter the liver, they form so this hepatocyte, so this will be infected with this sporozoite. So there is hepatocyte, so this hepatocyte will be infected with sporozoite, and there is what happens? So there will be a hepatic schizont formation will be there. So this hepatic schizont will form in the liver, and what happens is, so this is multinucleated, small things, okay, because of the multiplication. So it is a multinucleated schizont which occurs in the liver, and this schizont, it ruptures, releasing merozoites into the circulation. Okay, so what is first? Sporozoites, then hepatic schizont and merozoites. And here we have some sporozoites, they become the hypnozoite, that is the dormant form. So this dormant form, so this occurs due to infection with vivax and ovale. Few sporozoites, they become latent as hypnozoites, and they become dormant in cases of infection with vivax and ovale. So from sporozoites, what is happening? Hepatic schizons, and from hepatic schizons, merozoites. So these merozoites, so what will happen? They will infect the red blood cells. So merozoites, so they will infect the red blood cells, and in the merozoites, what will happen? Early trophozoites, that is, there will be a ring form in the erythrocyte. So this is a early trophozoite form. So first, from mosquito, what are released? Sporozoites are released. So these sporozoites, they enter the liver within 1 to 2 hours. So in the liver, they form hepatic schizons. The latent form of this sporozoite, which occurring due to infection with vivax and ovale, so these are hypnozoites. So this hepatic, so that is about hypnozoites. So later, what the sporozoites, they form the hepatic schizont, then they convert into merozoites in the blood. So this merozoites, so they infect the RBCs, and after this merozoites, they infect the RBCs, they form the trophozoite in the RBC. So this is the ring form of the trophozoite, and after that there will be a late trophozoite, and then blood. So after that, so it is a see here we have a pre-erythrocytic schizont. Even in the red blood cells, what will happen? There will be a blood stage schizont will forms, and after that, so this blood stage schizont, so this again this ruptures. Again, this will release all the merozoites, and again from this late trophozoite, from this early trophozoite, what will happen? A few gametocytes occur, and again these gametocytes, they go into the Anopheles mosquito, into the midgut of the Anopheles mosquito, and they proliferate here, and again when mosquito bites, no, all the sporozoites are released. So this is the life cycle of the Plasmodium parasites. So sporozoites are important: liver, hepatic schizons, merozoites, so early trophozoite form. Then we have a late trophozoite form, and then we have the blood stage schizont, and then we have the merozoites, and here there is a gametocyte, and this gametocyte, so this enters a female Anopheles mosquito, and then we have the incubation period. So following the, see, this mosquito comes and bites. So after this, what is happening? So the sporozoites are entering to the into liver within 1 to 2 hours, and individuals, so they are generally they are asymptomatic 12 to 35 days after infection. Okay, so infection is occurring, sporozoites are released, they are entering into the liver. So, but what will happen? So immediately all the symptoms won't manifest. Okay, so patient will be asymptomatic for 12 to 35 days after infection, but sometimes, no, symptoms can occur as early as 7 days. So when does the symptom occur? The symptoms occur when when the parasites are entering into the red blood cells. When the parasites are entering into the erythrocytes, then these symptoms occur. So these red cells, no, so they rupture, and what they cause? They cause a release of merozoites. So this release of merozoites causes fever and other symptoms. Okay, so immediately infection won't occur, so the incubation period will be around 12 to 35 days. So for P. falciparum, the incubation period is almost 1 month, and vivax and ovale incubation period is around 2 weeks, vivax and ovale, and the incubation period of Plasmodium malaria, it is 18 days. So the incubation period of Plasmodium falciparum will be 1 month, vivax and ovale incubation period is 2 weeks, and incubation period due to Plasmodium malaria, it will be 18 days. So see, what is the pathology is that pathology is like if so red cells are there, no? If red cells are infected with malaria, no, so these red cells, they undergo hemolysis. Okay, and because of the hemolysis, jaundice will occur. See, this falciparum, so this has got a tendency to invade red cells of all ages. Falciparum, it invades red cells of all ages, but this vivax and ovale, it preferentially involves the younger cells. Falciparum, red cells of all ages; vivax and ovale, the younger red cells; and this P. malaria, so this infects the normoblast. Okay, falciparum, it infects red cells of all ages; vivax and ovale, it infects preferentially infects younger cells; and P. malaria, it infects a normoblast. And anemia is profound anemia will occur because of the lysis of the red blood cells, and this anemia, so this is also worsened by depletion of all the folate stores because of splenomegaly and dys erythropoiesis. So anemia, it will be worsened by depletion of the folate stores in folic acid deficiency, when there is splenomegaly, and whenever there is dyserythropoiesis. So red cells are infecting malaria, and RBCs undergo hemolysis. In Plasmodium falciparum, what will happen is the red cells which are containing these trophozoites, okay, trophozoites are there in the red blood cells, no? So the red cells which containing these trophozoites, so what will happen? They will adhere to the vascular endothelium. So red cells containing the trophozoites, they will adhere to the vascular endothelium in the post capillary venules. So where does this occur? So this occurs in the post capillary venules in the brain, kidney, liver, lungs, and gut. What will happen? No? So this RBCs containing the parasite, they will adhere to the vascular endothelium by the help of the knob protein. So this occlusion, okay, so this occurs in the post capillary venules in the brain, kidney, liver, and lungs. And these RBCs which are infected with the parasites, they also form the rosettis, and Roulex formation will also occur with the uninfected red cells. So because of this, what will happen? Even the uninfected red cells, they also form rosettis and Roulex formation. And all this, no, so this total pathogenesis with this RBCs with parasites, what will happen? No? So this will cause rupture of the schizons, and it will liberate all the toxic and antigenic substances. So this Plasmodium falciparum, so this has influenced human evolution. See, in Africa and West Africa, what happens? So there are protective mutations from this Plasmodium falciparum, because they have protective mutations such as sickle cell hemoglobin. So all these are protective mutations from Plasmodium falciparum. So this occurs in West Africans and African Americans. So what are these protective mutations? So sickle cell hemoglobin, thalassemia, G6PD deficiency. So all these are the protective mutations. HLA-B53, okay, all these are the protective mutations. And this Plasmodium falciparum, no, so this does not grow in red cells. See, all these parasites have got a tendency for red cells, but if this red cells, no, if this contains hemoglobin F or hemoglobin C or hemoglobin S, so what will happen? So these parasites, no, so they don't grow in those red cells which have this hemoglobin F, C or hemoglobin S. And we have this Plasmodium vivax. So this Plasmodium vivax, no, so this cannot enter red cells which lack the Duffy blood group. So this Plasmodium vivax, it cannot enter the red cells which lack the Duffy blood group. So if this Duffy blood group, so these antigens, if they are not present on the red blood cells, so this Plasmodium vivax cannot enter the red cells. So these are the protective mutations, that is patients are having this type of hemoglobin or this type of RBCs, they are protected from this Plasmodium falciparum and Plasmodium vivax. So then, what are the clinical manifestations? So in the clinical manifestations, what will happen? Uncomplicated falciparum malaria. So in uncomplicated falciparum malaria, so this uncomplicated falciparum malaria consists of symptomatic infection due to Plasmodium falciparum. So the initial symptoms, no, so these are non-specific symptoms. So what are the non-specific symptoms? So these include tachycardia, tachypnea, chills, fatigue, headache, cough, nausea, vomiting, abdominal pain, arthralgias and myalgia. So all these are the non-specific symptoms in uncomplicated falciparum malaria. And if we take fever, no, so this occurs at irregular intervals. All the febrile paroxysms, so this occurs at irregular intervals, and temperature like it will rise greater than 40 degrees centigrade. So how fever, it will be irregular intervals it will occur, and in children, no, febrile seizures occur. But if this fever patients were having fever with generalized seizures, no, so this heralds the development of cerebral malaria. So patients who are having generalized seizures along with fever, it heralds the development of cerebral malaria. Okay, and so this febrile paroxysms, no, so this occur every other day for vivax and ovale and falciparum. Febrile paroxysms, they occur every other day for vivax, ovale and falciparum, and this febrile paroxysm, so they occur every third day for plasmodium malaria. Okay, so in plasmodium malaria, infection will be mild, but this chronic recurrent plasmodium malaria, so this will cause glomerulonephritis and nephrotic syndrome. So the febrile paroxysms occur alternate day, that is every other day for vivax, ovale and falciparum, and every third day with plasmodium malaria. Because of the improvements in the early diagnosis and treatment, what is happening? So this cyclic fever, no, so this is seen infrequently. So because of the improvements in early diagnosis and treatment, cyclic fever is seen infrequently. And then physical findings. So what findings can we see in infection due to malaria? So there will be anemia. So because of anemia, there will be pallor and there will be lethargy, and palpable spleen will be there. And apart from this, what else will be there? Mild jaundice will be there. Uncomplicated, there will be a mild jaundice. And coming to severe malaria, so complicated or severe malaria. See, this severe malaria not only with falciparum, but this might also occur with vivax, but it is most commonly seen with falciparum infections. So what happens in severe malaria? That is, there will be impaired consciousness will be there. Impaired consciousness, that is Glasgow Coma scale, no, it will be less than 11. Patient will have prostration, that is patient will have generalized weakness, that is he won't be able to sit, stand or walk without assistance. So what patient will have? Patient will have impaired consciousness, Glasgow Coma scale will be less than 11. Patient will have prostration, that is patient is unable to sit, stand or walk. Patient will have multiple convulsions, that is repeated convulsions patient will be having. Patient has acidosis, that is plasma bicarbonate, no, so this will be less than 15 millimole per liter. Patient will have acidosis, plasma bicarbonate will be less than 15 millimole per liter, and patient will have hypoglycemia, that is plasma glucose will be less than 40 milligrams per deciliter, and patient will have severe anemia, that is hemoglobin will be less than or equal to 5 gram per deciliter, and serum creatinine, no, so this will be greater than or equal to 3 milligrams per deciliter. And then we have jaundice. So jaundice, no, serum bilirubin will be greater than 3 milligram per deciliter. Along with that, there should be plasmodium falciparum parasite count greater than 2.5% parasitemia. Jaundice, that is serum bilirubin greater than 3 milligram per deciliter. Along with that, Plasmodium falciparum parasite count, so this will be greater than 2.5% parasitemia. So what are the different manifestations? Impaired consciousness, Glasgow coma scale will be less than 11. There will be prostration, there will be multiple convulsions, there will be acidosis, hypoglycemia will be there, severe anemia will be there, serum creatinine will be greater than 3 milligram per deciliter. There will be pulmonary edema, that is oxygen saturation, no, it will be less than 92% on room air. There could be significant bleeding from nose, gums or venipuncture sites, and shock will be there. Okay, that is systolic blood pressure will be less than 70 mm of Hg, and there will be hyperparasitemia. So that is in P. falciparum, no, what will happen? The parasitemia will be greater than or 10%. So there will be a hyperparasitemia. But for Vivax, no, there is no established parasite density thresholds. For falciparum, hyperparasites will be more, that is greater than or equal to 10%. So that is about severe malaria. So in severe malaria, we have the impaired consciousness, prostration, multiple convulsions, hypoglycemia, severe anemia, renal impairment, jaundice, pulmonary edema, significant bleeding, shock, and there will be hyperparasitemia. Then we have what is cerebral malaria. Cerebral malaria is nothing but it is a encephalopathy. Cerebral malaria. What is cerebral malaria? It is a encephalopathy. So this presents with, so what happens in cerebral malaria? There will be impaired consciousness. That is, there will be loss of consciousness. So there will be delirium will be there. There will be seizures will be there. So what are the risk factors for cerebral malaria? Like in which group of patients this cerebral malaria is known to occur? So this mostly occurs in children and older adults, pregnancy, poor nutritional status, host genetic susceptibility, and history of splenectomy. So what are the risk factors for cerebral malaria? Children and older adults, pregnancy, poor nutritional status, host genetic susceptibility, and history of splenectomy. So these are the risk factors for cerebral malaria. Cerebral malaria is nothing but it's an encephalopathy with impaired consciousness, and there will be delirium and seizures. And then how to diagnosis of malarial infection. So thing is blood smears. Okay, so these blood smears or genes are stained. Okay, so blood smears or genes are stained blood smears. So we have a thin smear and we have a thick smear. Okay, blood smears which are thin smears and which are thick smears. So in thick smear, what will happen? There will be mechanical lysis of the red blood cells will be there. Whereas in in thin smear, what will happen? In thin smear, there will be a mechanical. In thick smear, so genes are stained smear. Thin smear, what will happen? Thick smear, there will be a mechanical lysis of the red blood cells. But in thin smear, what will happen? The integrity and morphology of erythrocytes with parasites, they are visible. Okay. So thin smears and thick smears. So in thin smears, the red blood cell morphology as well as the integrity of the red erythrocytes, it is preserved. But what happens in thick smears? There will be a lysis of the red blood cells. So with thin smear we can tell the species. Okay, what is the species? Okay, and both thin and thick smears are used for quantification of the parasite density. Okay, and apart from this we also have rapid diagnostic tests. So thin smear, thick smear. So from thin smear for parasite for identification of the species of the parasite, and both thin and thick smear are used for parasite density. And then we have a rapid diagnostic test. So these rapid diagnostic tests, so they detect the antigen of plasmodium. So this rapid diagnostic test or for the detection of the antigen of the plasmodium. So what is the antigen? Histidine rich protein of Plasmodium falciparum. Histidine rich protein of Plasmodium falciparum and Plasmodium LDH for all species and aldolase for detection of all species. So nothing but we are detecting by rapid diagnostic test, we are detecting the antigen, okay, of the plasmodium. So HRP2, that is histidine rich protein 2 antigen for Plasmodium falciparum, LDH for detection of all the species, and aldolase antigen for detection, this is also for detection of all the species. And coming to the treatment of malaria. So in treatment of mild falciparum malaria, so what is the preferred therapy for the treatment of mild falciparum malaria? So the preferred treatment of mild falciparum malaria is artemether plus lumefantrine. The treatment of mild falciparum malaria is with artemether and lumefantrine, that is oral tablets. So given at 0, 8, 24, 36, 48 and 60. So for mild falciparum malaria you have to remember artemether and lumefantrine. And for severe falciparum malaria, IV therapy is preferred. Okay, IV what is given? Artesunate. So artesunate, how much it is given? 2.4 mg per kg IV at 0, 12 and 24 hours. So artesunate. So for mild falciparum malaria, what is given? Artemether plus lumefantrine. For severe falciparum malaria, artesunate at a dose of 2.4 milligram per kg given at 0, 12 and 24 hours, and then it is given once daily for 7 days. So the total cumulative dose should come to 17 to 18 milligrams per kg. Okay, severe malaria IV artesunate. And what are the adverse effects of the artesunate? The artesunate adverse effects include nausea, vomiting, and one more adverse effect which is more common with this artesunate therapy, it is delayed onset of anemia. What is the other adverse effect of this artesunate therapy? So there is a delayed onset of anemia. And then non-falciparum malaria. So that was about falciparum. Now coming to non-falciparum malaria. So the preferred therapy for non-falciparum malaria. See, a few regions, no. So there is resistance to artesunate. So this artesunate, no. So this is combined with other drugs like lumefantrine or doxycycline or clindamycin. Okay, so this doxycycline should not be given in pregnant patients. So the side effects of artesunate include nausea, vomiting and delayed onset of anemia. And then this non-falciparum malaria, so the treatment, the preferred therapy is, it's chloroquine. Okay, treatment of non-falciparum malaria is chloroquine. So how much chloroquine should be given? 600 mg chloroquine base orally, followed by 300 mg in 6 hours, then 150 twice daily for 2 more days. Chloroquine 600 mg base orally, followed by 300 mg in 6 hours, then 150 mg base twice daily for 2 more days. So this should be followed by primaquine. Okay, primaquine. So this is for patients who have this hypnozoitic phase. So this is seen with Vivax and oval infections. So for Vivax patients, so it is how much? 30 mg orally daily for 14 days for this hypnozoic latent phase. And for what is this? For oval infection, it is 15 mg orally daily for 14 days. So this primaquine has to be given after confirming that patient is G6PD. There is no G6PD deficiency. So if there is a deficiency of this enzyme, so this will lead to hemolysis in those patients if primaquine is given. So we have to confirm that patient is not G6PD deficient. And then chemoprophylaxis. So under chemoprophylaxis for malaria, we can give this, if there is a high chloroquine resistance, we can give this mefloquine and doxycycline. So in high chloroquine resistant areas, what is the chemoprophylaxis? So it is mefloquine and doxycycline. So mefloquine, so it will be started. So chemoprophylaxis means that is whenever a patient is entering into an endemic area. So this mefloquine, it will be started 2 to 3 weeks before travel. So mefloquine is given 2 to 3 weeks before travel and continued until 4 weeks after. So continued until 4 weeks after. And doxycycline, so this is started 1 week before and continued until 4 weeks after travel. So before travel 1 week and after travel to that area, it is continued for 4 weeks. This mefloquine 2 to 3 weeks before travel and continued until 4 weeks. So if there is an absent chloroquine resistance, so then chloroquine can be combined with progranil. So if there is chloroquine resistance is absent, chloroquine can be combined with progranil for chemoprophylaxis. So started 1 week before and continued 4 weeks after travel. So this is about malaria, and thank you.